Thank you very much for the opportunity and for inviting me to present on treatment-free remission in CML, our experience at MD Anderson, and whether TFR is a reality. So CML, it's a low incidence but high prevalence. It's a rare disease. In old days before 2000, the incidence was 4,000 to 5,000 cases per year in USA with a survival of 6 years. Therefore, the prevalence wasn't so high. We know that the prevalence has been increasing and will reach a plateau when the number of new cases, what you mean incidence, equal the numbers of mortality per year, and therefore get a plateau. But since 2000, CML mortality has decreased drastically to less than 1%, and therefore, while the incidence has been increasing a little bit, the prevalence has increased significantly because every year the mortality is so minimal and we have new cases added. Therefore, in 2022, the prevalence of CML in the USA is around 150,000 cases per year. And if you consider the world size 25 times the USA, then the world prevalence is $4 million and 4 million patients. And the plateau will only happen in 2040 when the mortality equals the number of new cases. By that time, the prevalence will be around 400 to 500 cases in the USA and 9 to 12 million worldwide. And therefore, it's very important to deliver a finite therapy because if we keep giving treatment for a lifetime, this will be associated with an enormous cost. So what are the agents available today in CML? There are several listed here. We start with interferon in old days, but then we had multiple TKIs. The first one was imatinib, approved 2001 for salvage and frontline 2002. Then we have dasatinib, nilotinib, and bosutinib are second-gen TKI, with all having the label in salvage and a frontline. Ponatinib was approved in 2012 for relapse disease, and asciminib was approved this year in 2022 for relapse disease as well. And we have a drug, what we call the non-tyrosine kinase inhibitors or protein synthesis inhibitor, omastaxine, less used alone. So the CML has changed drastically from a fatal disease before the year of 2000 with a poor outcome, survival at 10 years of 10%, and only those who are lucky receiving transplant and surviving with nothing for relapse, to today, a disease with indolent course, excellent outcome, survival at 10 years surpassing 85% due to the fact that we have multiple tyrosine kinase inhibitors, recently asciminib added, and allotransplant is only reserved for patients who failed multiple tyrosine kinase inhibitors. Here, I'm showing the survival at our institution from 1975 to 2019, and you see the top curve are CML-related deaths with TKIs, 95% survival at 10 years. So essentially, it's the CML-related deaths. So it's really great. And if you consider all this together, we're at 92% survival at 10 years. Then you can see the green curve are patients in whom they were on interferon and then later on did receive imatinib therapy, and yet they have a good survival. That brings me to share something with you today, and we publish on that, is that CML patient today can expect to have a normal lifespan. So here we're comparing survival to a normal population. We reviewed our own experience with 483 patients receiving imatinib or second-gen TKI, and you can see as long as you have a CCYR in green, the survival is close to normal population. So we can tell our patient today, the bad news is you have cancer. The good news is you will live a normal lifespan. No, the primary goal of therapy was overall survival, and we're moving into something else, and I will share data with you, is treatment-free remission. When can we stop therapy, and in whom we should stop, and how to monitor our patient after stopping therapy. So CML 2022, we have multiple TKIs, imatinib, nilotinib, ponatinib, and bosutinib, and recently we had asciminib approved, but we have new drugs available and will be available, and the closest one is HQP 1351, available in China and being tested right now in the USA. So the agenda for therapy, therefore, is imatinib 400 frontline option, dasatinib 100 mg daily at MD Anderson. It's 50 mg per day, and I will show you the data. Nilotinib 300 mg twice daily. I like to highlight the difference between the label in a frontline and relapse, which is 400 mg BID. Bosutinib as an option as well. These options in the second line, we have nilotinib, dasatinib, bosutinib, ponatinib, and asciminib, as well as omastaxine. And of course, transplant remains a good option. For advanced stage disease, I think we need to go beyond TKI to combination, combining with intensive chemotherapy, HMA, or others, I like to highlight that vaccine was approved for 14 days induction. I think it should be used for less than 14 days due to myelosuppression. In our practice, we use 2 to 5 days of sub-Q BID treatment. So important question CML is, what is the best frontline TKI, whether it's generic or branded Gleevec or second generation tyrosine kinase inhibitors? What is the endpoint of therapy? Are we aiming for a survival to induce a deep response, or cytogen response is good enough? And therefore, what will be the aim of therapy? Survival or moving into treatment-free remission? And if we decide to go to treatment-free remission, at what price? What are the drugs to be given? Long-term side effect and the cost, role and timing of allotransplant, monitoring of CML, TKI discontinuation, and salvage therapy. And I'll try to cover most of these questions during my talk with a focus on treatment-free remission. So 5 factors determine today the frontline choices in CML that include age, aim of therapy, cost, CML risk, and comorbidities. I give an example. If age and aim of therapy, and here we have 2 factors. Younger patients, therefore we aiming to induce treatment-free remission, then I do favor second-gen TKI. Dasatinib 50 mg per day will be my first choice. Alternatively, bosutinib, and alternative will be nilotinib. Older patient, therefore the goal of therapy is to improve survival. Imatinib is good enough. Cost of therapy plays a role. Patient who cannot afford out-of-pocket expenses, generic imatinib is available and very cheap in the USA today at $500 per year. And I hope in the Middle East is available as well at the same cost. No, things will change once dasatinib and the second-gen TKI will become commercially available and generics. CML risk, if I have somebody high so-called score disease, I'm very likely inclined to use second-gen TKI, dasatinib, bosutinib. And finally, the comorbidities will dictate my choice of therapy. Somebody with history of vascular events, I'm going to avoid nilotinib. Somebody with history of lung issues, I want to avoid bosutinib. And we know as well that patients with renal dysfunction should avoid bosutinib therapy. So these are the factors that determine how do I decide on a frontline therapy. And then how do I sequence my therapies, and what are the strategies in CML? Our frontline option in Janssen has been dasatinib 50 mg per day. This is the drug I use first. Then my second line will be ponatinib, 45 mg per day if TT59 mutation, and then 30 mg per day if no mutations. And once my PCR is below 1%, I'm reducing the dose to 50 mg per day to avoid problems of vascular events. If I have a specific mutation on dasatinib, like V2N mutation, then nilotinib will be my best choice. If ponatinib cannot be given because of toxicities, then bosutinib is my second choice after dasatinib failure. If I start on imatinib therapy, 400 mg per day, then my second choice will be dasatinib. 50 to 100, usually I go 100 and reduce to 50 once the response is achieved, or bosutinib as an alternative. And once I fail my second-gen TKI, I move to ponatinib. So essentially, I only allow a failure of 1 second-gen TKI and I move to ponatinib thereafter. I do avoid the use of nilotinib in the front line because of the risk of vascular events being 25% cumulatively over 10 years, which is 2.5 per year. And finally, I will always adjust the TKI dose if side effects before I consider a change of tyrosine kinase inhibitors. So here's some data on low-dose dasatinib in a frontline setting. The idea was that dasatinib is effective at a lower dose. The IC50 is excellent, and therefore, and we know from the decision trial that patient in whom we had to reduce the dose because of safety concerns, we did not compromise on efficacy. Therefore, we launched a study with 81 patients who received 50 mg per day of dasatinib. The 3-month response was below 10%, at 3 months was 96%, below 1%, 77%. And when you compare this data to dasatinib 100 mg per day, it's as good, if not better. You look at the cumulative response of CCYR at 12 months, 95%, and then deep responses by 12 months, the MMR rate was 81%, almost double of what we could obtain with 100 mg per day. The question is, why therefore dasatinib 50 is better than 100? It's better because we have way less pleural effusion and toxicities, and therefore we have less drug holding, better exposure, and survival of 100%. And based on this data, compared to imatinib and dasatinib, 100 mg per day, we established dasatinib at 50 mg per day as standard of care. Now, Then what we did, we compared the 50 to 100 milligram per day, and we found that in a propensity score matching, that patient who received 50 had at least a better equivalent outcome. Essentially, we had deeper responses being MR 4.5, CMR, and that translates into better failure-free survival, 89% at 4 years compared to 77% for dasatinib 100 milligram per day. The reason why is because we had way less myelosuppression and less pleural effusion. The rate of pleural effusion being 5% compared to 21%, grade 3 and 4 being 4%, being 3% compared to 10%, and therefore with better exposure. That's why the outcome is better with the 50 milligram per day. That's why we're using this drug today. Now, our colleagues in Japan have explored even lower dose with 20 milligram per day in older patients, those who cannot tolerate higher dose. They are 70 years and older. In a study of 52 patients, follow-up of a year, the cumulative rate of MMR at 12 months was 60%, with the 12 months MR4 being 27%. For pleural effusion grade 1 and 2 was only for 4 cases. So this is a proof that we can use even lower dose. I'm not saying we should start at 20 milligrams per day, but I think maybe in older patient with a poor tolerance to 50 or 100, we should reduce the dose to 20 to allow better exposure and maintain therapy and maintain efficacy. Now, imatinib is standard of care based on a landmark study called IRIS. 553 patients who received therapy with imatinib versus interferon. You can see here the cumulative rate of response at 10 years being 93% for MMR, MR 4.5, 2.3%. Now, what we know as well that in CML, the early response does matter. And because if you respond early, you can suppress the events in many transformation to almost 0%. The events happen early on. Beyond second year, we don't see any events. Why I'm saying the outcome of CML is highly predictable and patient can reach a plateau and have a normal survival provided they're taking their medicine. And here the events are mainly seen early on, less so later on. Despite the crossover design where patient on imatinib crossed to receive patient on interferon therapy crossed to receive imatinib therapy, you can see 5% survival difference from 78.8% to 83.3% at 10 years. Therefore, the message is whenever you have somebody with CML newly diagnosed, you must initiate therapy in order not to compromise on overall survival. So there's enough data on generic today, and then people are concerned about generics, but we have a bulk of data showing that generic are as good as patent imatinib when it comes to rate of responses, cytogenetic responses, molecular responses, PFS, and survival. And therefore, in USA today, at my institution, we use generic drugs for CML, mainly imatinib therapy. Now, the frontline therapy of CML, we had several randomized trials. All have shown faster, deeper responses, but none of them has shown a survival benefit. And this is mainly due to the fact that we have good salvage approach where a patient can fail frontline therapy, can get a second line and maintain the survival. However, one should keep in mind that the second gen TKI upfront are associated with some specific side effects, be it pleural effusion with dasatinib, vascular problems with nilotinib, and of course, renal dysfunction with bosutinib, and that can lead to non-CML increase of the non-CML related deaths. So several randomized trials were done, again, highlighted that the new drugs induce deeper responses compared to imatinib, be it dasatinib, nilotinib, bosutinib, or high-dose imatinib therapy. Therefore, if your aim is to induce a deep response, second-gen TKI are more important, and it's important because if you have a young patient in whom you want to stop therapy, you need to induce a deeper response, and therefore allow this patient to be a candidate for treatment-free remission, that I will come back to it. However, I'd like to highlight that with the long-term treatment, we have some adverse events being seen, and here data with nilotinib at the long-term follow-up, 25% cumulative risk of vascular events with nilotinib twice daily. Therefore, one should be careful and mitigate every factor that can lead to vascular problems. So which one is better, dasatinib or nilotinib? Similar efficacy, similar outcome. These are data from Japan, and therefore you can use either one. But my choice will be based on adverse safety profile, and we have a data with 50 milligrams per day being safer and equally efficacious. How do I treat frontline CML in 2022? Therefore, I think I use generic imatinib whenever I can. This is what I'll do. Approved dasatinib is 100 milligram per day, but I use 50 milligram per day. It's as effective, but half price. Bosutinib 4 milligram daily, but then eventually can consider dose escalation, 200, 300, 400 to mitigate the adverse events, mainly diarrhea early on, and that lead to treatment discontinuation. Nilotinib, associated with vascular events, use a lower dose if you can. Any of the above are good if your endpoint is survival. However, if patient has a high so-called score disease, and if my goal of therapy is to induce treatment-free remission, mainly in younger CML patients, then my choice will be on second-generation TKIs to be offered frontline. TKI choice depends on, again, age of the patient, cost of the drug, treatment aim, as I said, comorbidities, and then based on these factors, as I show you in the table, you can dictate your choice of TKI to be offered. Patient on CML should be monitored very carefully. I think PCR every 3 months in the first year until MMR for 6 months and more is observed. Then you move to every 6 months of PCR in a year 2 and onward. If you have a PCR increasing above 0.5% plus consistently at least twice, then repeat every 3 months. I mentioned that CCYR or PCR of 1% or less is a gold standard for survival benefit. MMR may decrease probability of relapse. However, you need to have a deep molecular response by MR 4.5 for 2 to 5 years at least if you want to offer treatment-free remission. And I think mutation should be only offered in a setting of failure, and the result should be interpreted in a context of alternative options available. So what are the endpoints of therapy? Survival, treatment-free remission, long-term safety, and the cost, what we call treatment value. How would you find deep responses? Deep molecular response means MR 4.5 with a PCR below than 0.01% international scale. Durable for 2 years and more, the TFR success rate is 50%. If you have a deep response for 5 years and longer, your treatment remission success rate is 80+%. And I will show you what we do in MD Anderson. So here are several trials done showing from Europe, essentially showing the rate of treatment-free remission. STEAM, Twister, and Freedom, they all show that success rate around 40% at the long run. We know this data from Germany as well, that eventually most of the patient can get to MR4, MR 4.5 in about 70 to 80%. And if you consider MR2, the vast majority can get into a molecular response too. This is in contrast with data from the randomized trial in SND, where this rate is lower, but this rate is lower mainly to the fact that patients on imatinib therapy were taken off study to move to something else, and the follow-up is still shorter. So the point I like to highlight is that patient can achieve a deep response. Of course, with second-gen TKI, this can be observed at a higher rate and faster. So here, the largest trial called EURISKI, where patients were offered a European study that was published in Lancet Oncology with an update last year at ASH, where patients TKI on for 3 years, when MR4 for a year and longer, were offered treatment-free remission, where PCR was done weekly at the beginning, and then every 6 weeks, and then every 3 months thereafter. This study included 728 patients, median duration of TKI being 7.5 years, and the median duration of MR being 4.5 years. So here the results have shown essentially 2 things we learned here. Number 1 is that the success rate is around 40-50%. Number 2 is that there's no plateau, means patients are still relapsing down the road. Therefore, one should monitor very carefully patients who are off treatment. What matters for the long-term outcome is that those who responded earlier and those who have been responding for a longer duration of time had a higher success rate, and the cutoff was 3 years in the study. This is a study from single institution where 128 patients in whom they stopped TKI, they followed them for a longer duration of time, and they showed that in this series, the TFR rate was 45.7%, and among patients who were followed, there were 14% who relapsed after 2 years. Therefore, we must follow these patients very closely, because we can have relapses happening later on, although not so common, but they can happen. And what matters for the outcome is that having a deep response, TKI duration, and duration of the molecular response, MR4 at least. This will bring me to compare why, therefore, there's a difference in TFR rate between the trials. It does depend on a treatment discontinuation criteria. Here the Euro key, MR4 for at least 1 year. STEAM trial, MR4.5 for 2 years and longer. So essentially, you have more strict criteria in a STEAM trial, and this is why the 2-year TFR was 50% in a STEAM Euro trial and 64% in a STEAM trial. No, can we do better? Here are the data from MD Anderson as published first. We showed that if you have a CMR for 64 months and longer, we have a great success rate. If you have a shorter duration of response, less than 64 months, you have more relapses. In fact, if you look at the patient 24 months and less, how many relapses of them? 75%. It dropped to 0% for those who had 96 months and onward. So bottom line is, I do offer therapy, I do offer treatment discontinuation in patients who had 5 years of treatment-free remission. Recently, we updated our data with essentially 297 patients. Half of them were low risk, half of them were intermediate. And then we look at the therapy they received. We look at the number of lines of therapy, mainly frontline therapy, and we look at the characteristics by MR4.5 duration of less than 5 years, 5 years to 6 years, and more than 6 years of therapy. And then if you look at the TFR success rate at 2 years, for those who had MR4.5 of 6 years and longer, was 91%. For those who had MR4 for 5 years to MR4.5 6 years and less, mean they have fluctuation of the level, 85%, and there was no difference between the two groups here. And of course, those with MR4 less than 5 years, the TFR rate was 67%. So in my practice today, I do recommend to have at least MR4 for 5 years, at least before I offer treatment discontinuation. And we look at the patient in whom after relapse, what happens to them? Well, they were able to regain their CMR or their molecular response in the vast majority. In fact, 81% regained CMR, and then 11% regained MR4.5, and they regain response within 4 to 6 months. Therefore, follow them carefully, and then you can reintroduce therapy if needed. So here I'm offering a table, ideal profile of a patient whom we can stop therapy. SOHO risk, low, intermediate, not high. Quantifiable transcripts, so you can follow them carefully. Chronic disease, not advanced disease. Optimal response, 8 years TKIs. But bottom line, you need to have a CMR or MR4.5 for as long as possible. I will say minimum MR4. I will say minimum 3 years, but ideally 5 years. And you need to be able to monitor your patient post-treatment discontinuation. This will bring me to our monitoring studies in USA in patient in TFR. Standard ELA and NCCN guidelines are to do PCR every month for the first year, then every 2 months for the second year, and every 3 months thereafter. I think this is too much. At our institution, we do PCR every 2 months the first year, then 2 to 3 months in year 2, then every 3 months in year 3, then 4 to 6 months in year 4 and onward. So every 2 months is good the first year. And I will only resume my TKI if my response is if my relapse is consistent with the PCR above 0.05% to 0.1%, and I will do it twice within 3 months of follow-up. So frontline therapy, how we can further improve on that? We completed the dazatinib venetoclax study. The results are not so clear yet, but right now we embark into a study of doing dazatinib 50 mg per day with oral decitabine. The aim is to achieve higher rate of durable molecular response and be able to offer treatment discontinuation and improve the treatment-free remission. So to conclude today, frontline therapy are excellent, getting better and safer. I think dose adjustment is very important. It doesn't compromise efficacy, while it optimizes safeties, and I think treatment discontinuation is really reality today, and you better wait for a long DMR, 3 to 5 years, in order to improve your TFR cure rate. And we have novel therapies available, and we're trying to optimize combination to improve TFRs, and finally, patient comorbidities should be optimized. Thank you very much for your attention. Happy to join the panel for discussion and questions. Thank you.